host is from Australia, so we are global healers. Some of you don't know me, my name is Dr. Tova Goldfein. I am a doctor of chiropractic and rehabilitation. My passion and my specialty is in helping patients with chronic pain and stress illness using amazing mind and body techniques. You know, Rose and I talk a lot about the doctor in you. So we want to hear from you. We want to hopefully have questions for you. We want to give you answers. And in all humility, we're just messengers here to help you find the doctor in you. And here's my co-host, Rose.
Good morning from Australia. Have you ever wondered what it's like in the operating theatre in the hospital? Well, we're going to find out this morning. Thanks for joining us again. Many of us are not only suffering from social distancing, but now, of course, it's relaxed a little, I think, all over the world. But job losses, loss of income, poor relationships, isolation from loved ones. We're missing our co-workers. We're missing that interaction at work. So now many of us have also lost loved ones, and to those people, we send our condolences. Look, I have a question for you. Is it possible to turn chronic anxiety and pain in your body and mind around and instead make yourself a source of strength, healing and peace in your own life? Another question. Do you think there will be a day when you desire to face your pain and that desire will be stronger than the pain itself? My name is Rose Hoey. I'm an ISDTP Psychotherapist, a modality that focuses on revealing the repressed or forgotten feelings hidden in the unconscious. The work is based on attachment theory and the unhealthy results from unrepaired attachment. ISDTP therapy releases us from our pain to live a happy and healthy life. This week, we're fortunate to have Karen Neaton, registered nurse and ISDTP psychotherapist. Karen has 30 plus years in nursing. We're going to hear some stories of pain management that will seem unimaginable for nurses and doctors with us today, all done by having an emotional feeling connection to the patient. Before we introduce Karen, let's take a few moments and release the pressure and stress on our bodies. Notice if you are tight around your shoulders, your jaw, your hips. Let your body drop into rest mode as you listen. Take a deep breath in, hold, exhale slowly, and let go of your tension. We will also do a short breathing exercise after our Q&A to finish off the program. So let us know where you are in the world right now and ask some questions. Any questions come to your mind? As we go along, Karen will respond to questions about her journey after her talk. So keep your questions coming. Dr. Tova will read them out and I will hand over to Karen now. She's gone.
She went for a run.
Okay.
At first she was blurry, and then
so she's dropped out. Yeah.
Maybe she re-entered, but we are ready to talk with her in a few minutes.
Good.
And until she comes back, I'll just check my phone. Rose, do you want to say something about?
Well, I'd just like to talk a little bit about Karen.
Wait, Karen's here. She's back.
Oh, good.
We are being challenged by the technical angels in this virtual world, which is a little bit new for Rose and I, but Rose is amazing. And last week we got through a little bit. She's here in a minute. I see her.
Oh,
Show
good.
her.
Okay.
Here she comes.
Yeah.
And I'm going to bring her up. Here comes.
just while we're waiting for Karen to come up, once she became an ISTTP psychotherapist, she realised she could use all these skills that we'd learned in our training at the bedside. Oh, here she is. She's back.
Yeah. How was your run, Karen?
No, she's still got
Oh, I just got
poor
so
reception.
meditation, I don't know where I went.
Okay, so listen, are you close to your router? Because you're a little bit blurry. Are you close to your router in your room? Oh,
She's
there
gone.
she goes.
Anyway, while she's coming back,
Yeah.
what she's achieved in the recovery room now is beyond amazing. I don't want to spoil her story, but over the years, she has often phoned me up and said, "Oh my God, you should see what happened in recovery room today. I had this patient who was in tears, and I just asked them about their feelings and what was happening for them. And then I find things like, my children are at home alone. I've got no one to look after them.
Wow.
Things
Wow.
like that.
Yeah.
And here we are.
Amazing.
Yeah.
Okay, we're good. Beautiful.
Well,
Welcome.
yes.
There you are. Welcome. From another
Thank
part
you.
of Australia, from the other end, the other side of the coast, from where Rosie.
No, same side of the coast, but up north.
Okay.
In the tropics.
Amazing. Welcome, Karen. We're so happy to hear from you.
Thanks, Tova. I hope the connection stays secure
Good.
so that
It's
it can be seamless. Yeah.
Good, yeah.
So would you like to start and tell us your journey?
Yes, well, I realise that this is the TMS RoundTable, so I've got so much passion around my work. I have to remember to stay focused on TMS, so I thought I would talk a little bit about the TMS that I had, talk about how I healed it, and then talk about how I see it in my patients and what I do at the bedside, if that's okay.
Fantastic. Go ahead.
Yeah. So, TMS is well, our listeners will know it's a term that's been coined by Dr. Sarno, and I've got his book just here, and I was refreshing my memory, and as I flicked through it, he said the first signs of TMS come at around 5 years of age. And I tried to think back of what I was like at 5 years of age, and I know I was somebody that had hay fever, so those sorts of seasonal allergies, and it's in the book as one of those presentations of TMS. And I wonder, what sort of happened before that? Was there anything going on before that? And quite recently, I was at a dentist, and TMJ was one of the problems that I had at one of the presentations of TMS that I had. And the dentist said to me, "Oh, you've had some stress in your life." And I thought, "Oh, how could the dentist know that?" And on the inside of my jaw, there was so much clenching down and grinding from a very young age that there's a malformation in the bone. So I absolutely love the way the body tells the story. So I try to think, well, maybe there was something going on even before I was 5 years old that meant that I was clenching down and biting my tongue, so to speak. And, we know that these types of things start happening as a result of, a relationship that we have with our caregivers and that perceives safety and connection and things like that. So I think, maybe I learnt to, bite my tongue from quite an early age. So I had hay fever. One of the other things, what else did I have? Then moving on to being a teenager, I had bad TMJ. I developed an asthma, and I also, just reading back through Sarno's book, I even had like a coccyx. I fell off a horse, but then I had this terrible coccyx pain for about months that I couldn't even sit down at school. So that sort of was a memory jog this morning. And then I moved into my nursing career quite young, about 17, and very early on I got nurses back, so I strained myself at work or something and had back pain and spent many weeks resting and with pain and getting back to work and those sorts of things. So I had the back pain. Then over the years I got diagnosed with other things, knee pain, chondromalacia patella. It was diagnosed at the time, plantar fasciitis, eventually reflux that came with pregnancy but then never went away. So I had lots of symptoms there. And so I realise now they were all part of TMS, because what happened for me is I had a traumatic life event and I ended up getting panic attacks, and that was something that prevented me from working. So I decided that I needed some help, and so I went to see an ISTDP therapist for psychological help. I had anxiety and depression, and as we worked on my emotions, what I realised was that all of those symptoms, they just all went away. So any of those presentations, they just went away and never came back. I didn't need medications anymore. And so I was convinced that these symptoms had an emotional cause. And so I decided, this is amazing, because I could see that in my patients all the time. So I decided to go off and do the training myself. So it's another 3 years. And so I started a private practice and I was able to practice there. But a lot of my practice came at the bedside. So I was working in the operating theatre. Most of my nursing career, I've worked in the operating theatre. It's a very stressful environment. And, patients, we know they have things like white coat syndrome, and, we fast them and we strip them off and it's cold and we take away their families. And so they're really in a very crisis type situation. So we see these presentations get exacerbated when people come to the operating theatre. So I was able to start using this increased capacity I have to ask people about what was going on for them. So is there anything up until now that you have any questions about?
Well, not yet. I think that people start to come on and want to hear more from you. Maybe there's a couple questions about, was there anything chronic that took time to go away? Because, just to get in front of my camera, because if there were various symptoms that absolutely seemed physical, like how did you start to believe that they were emotional? Like, reflux is reflux. Like, knee pain is knee pain. You fell off a horse, or, how did you believe that this was, how did you finally make the decision?
She didn't have to, did you? You didn't have to believe, because she was astonished that it had gone. When she, would I be right? Yeah, you're astonished.
That's right.
All these symptoms
the proof
were gone.
The proof was in the pudding. When people start to look for ways to cure their TMS, and they get told that perhaps it's psychological or emotion-based, they find it hard to accept that. A lot of patients do. And so they've got these physical problems, and then they have to accept that it might be emotional. For me, I had an emotional problem and I wasn't even thinking about these other symptoms. So I was open to dealing with my emotional problems. And so I guess that's one of the keys, is that if you can be emotion focused, the rest just drops away. Yeah.
So tell us about those amazing changes that you are able to get with your patients, and drop their narcotics, and just do pain management rather than emotional management, or ignoring emotional management.
Yeah, well, when I started my ISTDP training, I was working in the recovery room at the time. And so that's the area where people come from the operating theatre to get woken up from their anaesthetic before they go back to the ward. So it's quite a shut-off place that people don't get to see. So there's a bit of mystery around it, and patients don't even tend to remember what happens in there. But it really is, it's been really amazing for me to see what happens there. And I've started to wonder, in my practice, because certainly what I do at the bedside with people when they've had strong medications, it seems easier than what happens in the therapy room. So I don't know if it's the rapport that we've built up, the trust they've given me from the outset, or whether it's the medication. Maybe it's a combination of both, but the process often happens much easier at the bedside in the hospital. So the patients come out from the operating theatre, and a lot of them are still unconscious. And so we just, at that stage, we're protecting their airway and watching over them every moment while they're there. And when they wake up, it's interesting. A lot of people, the first thing that comes out of their mouth is not something that you would expect. So, for example, at work, I was a 20-year-old who's having back surgery. The first thing he said when he woke up is he said, "Can I have an erection?"
I'm scared.
That was one of the risks that he was told about the surgery.
Oh.
And obviously that was a concern for him. It was the first thing on his mind, and that was his biggest worry. And so that's what came out of his mouth when he woke up. And so having ISTDP's given me that capacity to stay with people with their concerns, to not be feeling shy or worried or dismissive. I can recognise those things because, when this young man said that when he woke up, there were other nurses around, and it's interesting that 3 or 4 of us had very different reactions. So you need to be able to meet patients where they are. So that kind of takes me back to, Rose was talking about attachment theory, and how my TMS, it developed as a young girl. And when I started to study and look at attachment theory compared to what my nursing study was, what I noticed was the one thing that the literature had in common was this term caregiver. And so to me, I thought, this caregiver role, it's such a big responsibility, both as a parent and as a carer in the hospital. So, and I wondered too, psychologically, if patients were reenacting with us perhaps what they did,
Wow.
with their parents.
That's amazing. I mean, this guy felt very safe to open up his heart and say what was on his mind. Like, it was really, really think about the connection he felt to ask you that, the safety. That's a very, very good point. It's a very, very amazing point about nurses. And I think people do it with doctors. They give them this sort of like, you're the parent. I'm going to listen to you.
Yes, they do. They do. And I guess that leads me to one of my stories at the bedside. This lady, she was brought to the recovery room and she was still unconscious. The anaesthetist said to me she was very anxious when she went in. She said he told me she was singing. So we know that that's a defence. When people are acting inappropriately, it's a defence against feelings. So we knew she was anxious. Her defence was she was singing, and then she went off to sleep. So he told me that, she was very anxious and that in the past she'd had a lot of nausea and vomiting, so much so that she couldn't go home. So we were going to try and manage her nausea and vomiting, and he didn't know if she was going to get to go home today or not, depending on how sick she was, because we have to make sure that people can eat and drink and keep food down before we send them home. So I was waiting for her to wake up, and I thought this will be interesting because we know that nausea and vomiting is also a somaticized form of anxiety, similar to what TMS can be. So I thought if she was anxious and singing, perhaps this can be dealt with emotionally. So when she woke up, I started to ask her emotional-based questions because I thought I didn't want the anxiety to go to her, smooth muscle and make her sick. So she very quickly started to tell me that she was a victim of childhood sexual abuse, and we talked about that quite openly. And during this time, she didn't get nauseated, she didn't vomit, she didn't ask for any medication. And the anaesthetist came out to check. I said, oh, she's fine. We're just having a chat. But obviously the content was quite different to what most people expect a nurse and a patient to talk about, you know, who's going to look after you or when are you going home, you know, just the logistics. So we were sort of talking about that part of her life. And then, so because she was going to be a day surgery patient, we would always follow them up the next day with a phone call. And I said to her, do I have your permission tomorrow when we call you to ask you about this conversation that we've had? She said, sure. So the next day when I rang, I said, you know, how are you going? Have you kept your food down? Did you get sick? Have you had any pain? I said, do you remember the questions that I was asking you? She said, yes. And I said, what are your thoughts on that? She said, I want to tell you to fuck off. And I was really shocked. But then I thought, that's right. You know, I was asking about painful things. And she, you know, that would generate some strong feelings. And I guess that's how she articulated it. And then I thought, well, but she didn't. You know, she didn't tell me that at the bedside. And it just took me back to the vulnerability of having someone's life in your hands and how people can, like I used to, bite my tongue. And so, you know, I think we have to be really cognizant of this idea that we are their caregiver, that psychologically they feel their life is in our hands and that it's a very vulnerable state. And so, yeah, we need to respect that.
Wow.
The anaesthetists have been, and the other nurses often ask you, what's going on, don't they? How come that patient left recovery room so quickly? You know?
Yeah, I've got lots of lovely.
Tell us a little bit more about
anxiety. Yeah, anxiety somaticises in lots of different ways. There was another lady. She came out to me. She wasn't quite unconscious, but quite drowsy. And the anaesthetist handed over to me. She was anxious as well going in, and that she'd been in hospital before. She'd had an episode where she couldn't go home. She developed asthma, breathlessness, and had to stay in. So I thought, excellent. So she had her puffer there with her. So she had it with her going into surgery. He said he didn't need to use it during, but she felt she would need it when she woke up for her breathlessness. So when she woke up, I was talking to her. I said, how's your chest? So rather than talk about breath, I just started to hone in on where she was somaticizing her anxiety. I said, how's your chest? And she said, it's okay at the moment. I said, and then I went to her eyes for some reason. You know, you get a bit intuitive with this work. And I said, you look like you want to tell me something. And she went quiet. And I had two patients at the time because, you know, she wasn't unconscious. We get a bit busy and I was walking away. And I said to her, it looks like, you know, you want to say something. But I said, is that right? And she just nodded at me. I said, so there's something you need to get off your chest. You know, I started to make a link between this heaviness she had in her chest, what seemed like breathlessness, but in fact there was just something she had on her chest that she needed to get off her chest. So I could see how reluctant she was in her eyes to share with me what it was. And I said, well, you know, it might help you with your breathing if you can get that off your chest. And I just made those connections without telling her she had to say anything. And I said, I'm just going to do this with this patient now, and then I'll come back. But you can tell me, you know, if you need to get it off your chest. And when I went back to her, I said, do you want to get that thing off your chest now? And she nodded at me. It was so hard for her. I could see how physically hard it was for her. And I said, what is it? And she said, I found out that my husband of 18 years has another family in another country. And she said, nobody else knows, just me. And I just affirmed, I said, that's a very big burden to carry on your own, and what a secret, and how heavy that must be, and burdensome. And she cried, and she felt better in her chest. She didn't have breathing problems. It wasn't heavy. She didn't need her puffer. She felt she could go home. So she may not even remember that, given that, you know, that was that post-anaesthetic phase. But just being able to do that intervention and to get her, you know, to get that opportunity for her to get that off her chest, it made a difference to her admission. And she looked so grateful, and she was very grateful. She was able to share that made a big difference, and what a secret it was, and what a burden it was. So, yeah.
The other thing, Karen, is you often, because you worked in the maternity area as well, you had a lot of sadness and grief with mums coming with babies in intensive care, or babies dying at birth and that. Could you just sort of recount a little bit of that, and how in our system we don't give the patient that chance to grieve the pain that they've of loss? Can you? There's a couple of those that have been very, very poignant, as you've told me over the years, and I think that our viewers would like to hear that, because many of them have lost their babies, and no one listened to them or heard them, and they had to go home with no one in their arms. Do you mind sharing some of that?
Yeah, no, not at all. So there's 3 stories here. So one is, I did a small research project as part of my master's, and it was based on a letter that we received from a patient saying that, you know, how much anxiety she had coming to hospital, and that she recommended that we do trauma-informed care, and she outlined all the aspects of trauma-informed care, and it was very articulate. It was an amazing letter, and I asked for her permission to use that in the research and educating different health professionals. She said absolutely. She was very excited actually that her letter actually was going to make a difference. What I did was I interviewed nurses about, you know, what would stop you addressing someone's anxiety or addressing someone's emotional pain when they came in. Well, you know, nurses invariably said they didn't want to upset the patient, but they just didn't want to go there. They didn't know what was next, you know, so they didn't feel they had that capacity to stay in that painful situation for the patient. Yeah. So there are 2 examples I'll give you. One is of a lady who she'd had a miscarriage early on in a pregnancy, and she was actually a friend of mine, and she went into hospital, and she told me how she'd been given these strong painkillers and she felt really bad, you know, groggy, that sort of hungover feeling for a couple of days, and it kind of delayed the grieving process and dulled it all and made it all very heavy. Anyway, I talked to her about what I'd found out with the research, and sometimes the nurses don't know what to say, you know. And she said, yeah, I just remembered the nurse kept saying, do you want some pain relief? Do you want some pain relief? And she said, eventually I said yes to make the nurse feel better. And so it's interesting, you know, like the patient, we're not there, you know, we're there for the patient. It shouldn't be the other way around. But she certainly felt that way. Unfortunately, she had a second and then a third miscarriage, and she remembered our conversation, and when she went back to hospital, she woke up and she almost encountered the same situation. The nurse was saying, do you have any pain? Would you like some pain relief? And she said, no, I just want to talk about this baby that I've lost. Wow. And she said, you know, once the nurse sort of gathered her thoughts, you know, just getting that off her chest and being able to say that, you know, no, this is the pain that I've got compared to needing some medication. And she said that was a much better experience, because she said she didn't feel she needed the pain relief. She was able to articulate what it was she needed, and then the nurse could meet her in that place. So I think as healthcare givers, we need to make sure we're addressing what it is the patients need.
Karen?
Yeah, without our own fear
Yeah.
coming up.
Yeah,
I mean,
it's Karen. I just want to say something. It's, I speak to a few of my male patients who, we talked about this in 2 weeks ago, our show, where we had two fathers on, and one was a doctor. And we talked about, when someone has to man up and he can't be emotional. So we're talking about a cultural thing that people are being shut up by medication in a way, and we have an opiate problem all over the globe. And so it's all coming together that to express emotions is healthy. To express emotions is human. To have emotions is not female or male. And especially TMS, and I always say you're a strong and sensitive person. We're sensitive people, and I don't think we're all very different from each other. So we're talking about an incredible concept that I think our mind-body work is answering this big question. And I hope people just feel safe, more safe and more safe to express feelings. And it's strong when a man cries. It's strong when a woman expresses her feelings. I don't know where we got the feeling it's weak, and I guess that's a whole nother show. What do you think about that, Rose?
We've got lots of people lined up, haven't we? Karen, what would you say now to patients that come to you for therapy? Like, do they come for their back pain, or do they come for their relationship problems? Do you question them on their back pain?
Yeah, it depends on how they've come to know about me. If they've got physical problems that a doctor has thought that maybe this is emotion-based, they'll get a referral, and so they'll come with physical problems to have a chat because they've reached the end of the line with investigations and things like that. People who self-refer tend to have more anxiety, depression, emotional problems, and haven't even twigged sometimes yet that some of the relationship problems and physical problems they're having are related to that anxiety. So it just sort of unpacks.
Yeah, and just talk about a moment about that unpacking, because it's sort of like there's these aha moments, aren't there, when they realise that they've held on to strongly held on to a belief or whatever, and they haven't accepted the what is or whatever of their lives.
I'm just going to go with the flow here. I've just had a thought of another patient, but it's actually back at the bedside again, so I'll go there. Because the work is easier. It just flows better post-anaesthetic. And, I mentioned before there was on 60 Minutes here in Australia just last Sunday, there was a story about psychedelic medications and how they help people to unpack a lot of this stuff. And I wonder if the anaesthetic does the same thing, because it just seems easier for people. So getting back to helping people.
You mean unpacking? It's like It's like they're more vulnerable. They're more open to talk about things when they take anesthetics.
It seems that the defenses are not up. They just seem more open. Yeah.
Wow.
So this was another young man, and he had been anxious too, and he had a light sedation, but then he was very, very chattery. And so we know that incessant talking can often be a sign of anxiety as well. People want to discharge their anxiety, so they talk. And he was talking so much, it was difficult even for us to get a proper medical handover. And I said, I'm going to just ask you to stop talking for a minute. We're going to hand over and then we'll come back to you. So he was quiet there for a while. And so I thought, rather than just say, okay, you can talk now, I thought, I'll just help him to try and understand it. I said, what's all this talking about? And so he just said, oh, I tend to talk a lot. Actually, I'm feeling a bit nervous. And I said, yes. I said, it's been, we had to do that handover. I said, actually, there's a few things that I need to do here. And he had come in to have a cystoscopy for bleeding from his penis. Anyway, the cystoscopy found nothing. And so when that happens, I immediately start to think, okay, there could be something else going on here. So I said to him, one of the other things I'm going to have to do is to check your penis while we're here. And he said, I don't have a very good relationship with my penis. And I said,
Wow.
Really? I said, why do you say that? And he said, oh, it just, goes off at the wrong times, And I said, well, you're 18, that would be normal. And he burst into tears. I said, what's the tears for? He said, nobody's ever told me that I'm normal before. And he cried and he cried and he cried. And then he started, then the life story comes out, the bullying at school and the difficulty fitting in. And so so we didn't talk about, did he injure himself or did he imagine this, something happening with the bleeding? But I just wonder, he believed he had a bad relationship with his penis. He believed that he was abnormal. He was holding in a lot of tension and sadness and rage about bullying and not being able to fit in. So he was quite calm then. He didn't need to chat too much. We had a dialogue, so there was more questions, answers, curiosity. He was calm, and then he was very thankful, and so he was able to go home. Yeah.
Karen, I think you would make a great nurse and a great psychotherapist.
Thank you.
Really, it's amazing what they share with you. It's unbelievable, the depth of first of all, they're feeling safe, and whether I'm just blown away. And I think you have to be very strong and sensitive, like you, to be in that nursing room. And thank God there are nurses like you. I mean, this is the future of. Wouldn't it be amazing if nurses and doctors would learn about this? So I'm really so happy to meet you. We're going to get a few questions.
Well, there are a number of nurses and doctors now that there are a number of doctors, especially a number of psychiatrists. This area was really more for psychologists, and now it's and psychiatrists. But now we've tried to put some pressure on getting it into ED, but we haven't been very successful yet. But
what's ED? Education.
No, emergency department.
Emergency department. Yeah,
because that's sort of like where it needs to go.
Right.
So that nurses and doctors, especially there, ask patients about their urinary tract infection or their cardiac problems, all those things. They're all related to TMS.
Right. Yeah. So here's our question.
If they were met at, yeah.
Let's see. Let's see if we can all answer it. My hip joints and sometimes back crack a lot more than previously. The other day I rolled over and it all cracked. I want to get over my obsession with the popping and pay less attention to it, as I know it's harmless. So as a chiropractor, first of all, I want the entire world, the entire globe to know what that cracking sound is. It's just bubbles in the joints. Chiropractors gently manipulate joints. We don't do anything to bones. So number one, it's important for everyone to know it's a natural sound when you're moving that you sometimes get a pop. If it's happening all the time, it's because something is not stable in your body and it's either too tight or too loose, the joints and the muscles. So that's just about that. And of course, focusing on it is like a spotlight. So Daryl, if that's the obsession, I can understand that you want to get over it. So I'm going to give you one tool, and then I'm going to let Rose and Karen give you another tip. just so you know, what you resist persist. Or I read something today in one of the books about neurons that fire together do what?
Wire together.
Wire together, meaning if you are going to, the same thing happens all the time, and you're just expecting it, creating it, more like it's your perception of it, like it's just where your focus is going, so it's going to continue to happen. So one of the tools is to just recognize it, be aware of it, say, oh, there's that popping again, and then move away, move on. That's one possibility of how you can handle it. You can also, I'll let Rose answer, because she'll probably have something to say about that, but it's a good question, especially for me, but I want to hear from you.
Well, I would be asking about what was happening with the muscles and the tension in the muscles, the striated muscle. Yeah. What would you say, Karen?
I would try a technique that I use at the bedside. I would say, okay, so you've got this very distracting cracking and popping. If we could take that away, what else would still be there?
Yeah, that's an excellent question.
Yeah.
And you use that often, haven't you?
Yes.
When patients...
Excellent. So Daryl, ask yourself, if the cracking wasn't there, what would be there? Is that right, Karen?
That's
Excellent.
correct.
Excellent.
Yeah. Actually, talk about the scenario of the patient being unable to settle their pain, and the anaesthetist came in and was offering ketamine or whatever, and then you asked the patient.
Okay. I think I know. I think I know
you tell
the story. Okay,
yeah.
There's so many stories, but I think this might be the one. So this lady, the theatres tend to ring ahead if they're bringing someone out, so that we make sure we've got space for them and there's a nurse ready. And so they said, okay, there's a patient coming out, to bay 1 or something. I said, okay, yeah, I'll take it. And I went, oh, that'll be my patient coming now. And you could hear them screaming down the hallway. So I thought, oh, this is perfect. This is perfect for me, perfect for her. So she came into the bay, and she was, I mean, people have pain, but she was loud and screaming, and, she looked like she was in pain. And the anaesthetist was trying to hand over. He said, she's against epidurals. I've tried to tell her she needed an epidural, and she wouldn't listen. And so now she's had a general, and now she's got all this pain. And she, so we'll just have to see what we can do. Anyway, I was giving her some pain relief to try, because we try to, I mean, some of the stories I've told you, it sounds like we don't give out pain relief, but we actually do. So people get pain relief if they need it. So clearly she was in pain, and she was describing it as like 12 out of 10 pain. And he said, see how you go with what with this pain relief. And anyway, so I was giving her lots of narcotics, and it wasn't working. And he then, because what they do is they hand over. We spend some time trying to manage their pain and calm them down, and then they go away, and usually we just get them better or whatever. Anyway, he said, just let me know how she goes. So we do what we call a round of pain protocol. So that's quite a large dose, and it hadn't touched the sides. And I called him back, and he came back. He said, all right, we'll give her some ketamine because we just need to try and calm her down. This medication is really strong. A lot of people know it as the horse tranquilizer. Wow. So she had some of that, and she actually went back to sleep. So while she was asleep, he said, look, what I think we'll do is we'll take her back to theatre and give her an epidural. And I thought, hang on, she's against epidurals, And he said, so, when she wakes up from her ketamine, I'll talk to her. about that. Oh, I said, okay. So as she was coming to, because, you know, it's a very strong drug and it induces a bit of a dream state. And I said to her, you know, you're waking up now, you know, your operation's finished. I said, how are you feeling? She said, oh, I had this dream that, you know, that I was, you know, screaming and there were all these doctors there. And I said, that wasn't a dream. I said, that was real. I said, actually, you've had your operation and your pain's not reflective of what you've had. I said, what is that pain? And she burst into tears. She said, you know, 21 years ago, I was in labour and the epidural didn't work and no one believed me. And she said, I spent 2 days in agony. And when I saw her in the bed, she looked like a woman in labour. She didn't look like a woman waking up from anaesthetic, you know. So it made sense to her. And I said, so what do you need from me? She said, I need you to believe me. And I said, I believe you. And she didn't need anything else.
Oh, wow. So unbelievable.
Incredible, isn't it?
Yeah, so I said, going forward, you know, what else do you need? She said, well, I need the nurses in the ward to believe me, you know, if I tell them that I'm in pain. So I said, well, look, we'll go there together. We'll get your team there and I'll tell them and we'll talk about it and I won't leave until you're happy that you can trust them. Is that fair? And she said, yes. So that's what we did. And I left her on the ward and it was all good. And I came back and the doctor came out to find her to tell her he was going to give her an epidural. I said, she's fine. She's gone. So it was a good outcome.
It's amazing. Karen's also spoken to theatre staff, haven't you, in various hospitals? Mm-hmm. And also she's spoken at anaesthetic conferences, haven't you, in recovery room conferences to other staff. Yeah. Wow. Do many come up afterwards and ask you questions?
Yes and no. Just quietly, they'll say, I loved that present. Like they realise it's the truth when they hear about anxiety and they hear about presentations. People recognise the truth when they hear it. And so, you know, we're all human beings and so we've all been patients and we recognise that, yes, that's exactly what happens. So when you're speaking the truth and when you can express that, then people recognise it for what it is and it touches them and they feel someone's seen them.
Beautiful. So here's a question from Lorraine from Canada. I've always been one to express my emotions, which why I'm always questioning TMS. Is my reason for chronic pain I currently have. So however, I have had tremendous amount of stress throughout my life. I'd also describe myself as a very, sensitive, feel things deeply personality. So I'm just going to say one very simple thing to you, Lorraine. We can express our emotions personally. Yeah, we can be very expressive, but it doesn't mean we're in touch with what we're feeling or that we know what we're feeling or that we are not repressing those feelings. That's my answer to that. It's a very good question and it can be confusing and I understand your dilemma. Do you understand the question, Karen and Rose? What do you think?
Rose?
Well, the feeling's in your body, and instead of the feeling, it's the pain that's in your body at the moment, isn't it? So while you hold on to that obsession, as they say, about the pain, you haven't got a moment to sort of think about what the feelings are in your body. Feelings of grief, sorrow, anger, love, all those feelings are all waiting there to be exposed. But you have to give them permission to let them out. You have to give them an opening to say, I care about you. I care about my feelings. I care about you as me as a person. That my heart has to be allowed to be opened and free. And the pain is there to keep you from exposing that area, because it would be too dangerous as a little child maybe to speak out loud about what was bothering you. And that's what I love about what is happening in theatre with Karen in Recovery Room, because all the defence work is there, the anxiety's in the forefront, and she's able to address the anxiety completely. Whereas in a therapy room or like here on these sessions, the defences are there first to hide the anxiety, which is going to block down the emotions or the feelings in your body that want to be expressed but are being held back. Have you got anything more that you could add, Karen?
Well, I would say trust your body. It's talking to you. So the TMS, as painful as it is, it's your body. It's talking to you. It's a bit like those little growths that I've got inside my jaw. I feel them every day, and I think, my body's talking to me, so I know more about myself. And if the answer's on the other side of that pain, and you may end up needing a good therapist to help you to track where that wants to go, because I know I did. I didn't want to know that I was angry at my mother. I just didn't want to know. That wasn't possible. I couldn't go there, and everything in me was so resistant to that idea. But I trust my therapist, I trusted my body, and I went there. And, when you're with somebody together, you can face it, once the trust is there and the TMS goes away. So it's such a wonderful feeling when you trust the process. So just listen to your body, trust that it's talking to you, stay engaged with it, and you might need help to get to the other side, because I know I did.
It's great advice. Great advice, Karen. Janet says, I have complex PTSD. What is that again? PTSD is
post-traumatic stress disorder. Yeah.
I have a lot of difficulties after surgery. Wow. Great hearing you speak, Karen. Wow. Amazing. Is Janet from Australia?
Yes, she's from Queensland. Yeah. Janet is an amazing artist, and she channels her pain and disability into beautiful art. And she's also written a book, and she's had a lot of trauma. So Janet said she was going to be on this morning. So I'm glad you came on. She actually asked a question prior to the live this morning about going to hospital, which I answered on the page. Yeah.
Wow. Amazing. Amazing. And I think just the few more things. There's no more questions right now. Well, I really wish there were. Here's another. I really wish that nurses. I wish I could do something with my 25th hour of the day to help nurses. This is so important, because the nurses would help affect the doctors. The nurses, just like the women of the Bible, the women can change the world. So I'm thrilled. And I do know about this nursing organization in America that are coming together to help learn this. So I think you're a pioneer. Same thing with Rose, who's a nurse and a midwife, pioneering in Australia. And I'm just so happy to know you. And whether you're nurses out there or doctors, put your seatbelt on. This is the future right here.
Yes, it definitely is the future. Yeah. And more and more, we've got an ISTDP nurses group on Facebook now. Yeah. So if there's any nurses out there, please ask to join so we can open up your scope of nursing practice. Karen also is part of university. You're a tutor, aren't you, Karen?
Oh, yes, I am involved in the a master's program.
Communication. Yeah.
Doing a little bit of work there. Yeah.
Yeah.
Wow. I
In
want to ask.
communication.
I want to ask a quick question. Daryl wants to ask something else. He's going to come on in a minute. But while he's working his question, Lorraine, loved your answer. It was very helpful. Yeah,
Oh,
feelings
good.
were yeah. While Daryl is writing his question, what I want to say is, in Israel they have chiropractors now in the hospitals, and I think it's a matter of time before every patient will have a a psychological consultation. I think it's just a matter of time. I think it's not the future. I think it's here, and I'm so happy to hear from you, Karen. So Daryl's asking another question. I get pain sometimes and sometimes not when I sit, and that was due to being told posture all over the years because he's an office worker. I read Dr. Sarno that he calls this conditioning. Any chance you could advise on addressing this? He's a social worker. And
good. Well,
yeah.
maybe he can join our TMS, our ISTDP group, because if you'd have an opportunity, a lot of ISTDP therapists are social workers as well.
Yeah.
Well, you could advise on addressing this.
Listen, the posture, I want to say something as a chiropractor and, living with gravity. We all have to live with gravity. It is a force that we don't feel or touch or taste or hear. It's there and it's pressing on us all the time. And now that we're industrialized, we're constantly facing forward and looking at phones and computers, and none of us are immune from that. I think posture is important. In a ways, your muscles are the levers of your body. They're moving your body and they surround every organ. Posture is very important. But it is part of the biomechanical way that our body functions. And I think with ISTDP, something very interesting with posture. You want to talk about that in pain and looking at the body?
Definitely. I would say, Daryl, that you have some weight on your shoulders, a burden, a loss maybe, that you're holding on to, and that's weighing you down.
Wow. Because people don't have, posture that they're slouching. You're saying unless something may be emotional, may be adding to the slouching. It's not just gravity. They're letting gravity pull them down. Like they're participating in that.
The weight of emotion that's unexpressed shows up in the body all the time.
Yeah, that's very true.
And that's what Karen's finding at the bedside, isn't it? That you're able to address it immediately and you're able to spot it through the body. Yeah.
I think that's what's amazing about ISTDP is that we're looking at body language. And I remember doing a report in college on body language. I mean, if we think about our patients and we look at their body language and their expressions, and then before they even say anything, we're learning about what the body's saying. It's speaking something.
Yeah. Well, when we've learned ISTDP, we're often asked by our supervisor, for example, what was your perception of what was going on within the patient? And of course, we've had to learn about mirror neurons and how we can, as working in an attachment model, actually mirror what's going on for the patient internally. And I don't know how it happens, but it's an amazing thing when you can feel like the grief or the sadness coming up in the person and they're not able to express it, but you can feel it in your own body and you're able to verbalize it for them.
Unbelievable.
And I mean, that's exactly what Karen's talking about at the bedside. She's able to spot it like
Yeah, and I think that it's really important to think about what's actually happening in the moment. You know, we can say, all right, patients want to feel safe, let's create a sense of safety, but that's not always the case. And, you know, like, for example, we have patients that have, you know, attempted to take their life, that come to surgery. When they wake up, they don't want to be safe. And I had an example of this. A man was coming to the recovery room. He was trying to get out of the trolley. He was a big man. He was fighting and swearing at the anaesthetist. And I could hear the anaesthetist. He had great intentions. He was saying, you're safe, you're safe, you're safe. And I went, hang on a minute, let me handle this. And so we got the handover, and the anaesthetist was, you know, trying to calm him down, saying, you're safe, you're safe, you're safe. But when the anaesthetist left, I said, what's going on? He said, I didn't die. I said, no, you didn't. You're alive. What's going on? He said, I just wanted to die under that anaesthetic. And I said, okay, you've obviously got a lot of pain there. What's going on? You know, his wife had committed suicide a couple of months before. He had now palliative cancer. And, you know, he had had a psychiatric consultant about 12 hours prior to surgery. And so, you know, he thought that having that surgery was going to be his way out, you know, and then it didn't work. And so he didn't want to be safe. So you've got to remember, you know, telling people they're safe just for the sake of it is not necessarily going to make them feel heard. So it's that recognition of what's actually on the forefront of their mind more than safety. It's being seen.
Yeah. And I mean, that's often what they say. No one has ever spoken to me like this in my life.
Yeah.
No one has ever asked me those questions in my life.
Yeah.
No one's ever been as direct as you've been in my life. And
No one's ever told me I was normal. I mean, that's really, really amazing. Really amazing.
Yeah.
So, Rose, you want to lead us in a little bit of meditation?
Yes. Thank you, Karen, for
Thank
your
you, ladies.
For your journey through your own personal life and through your nursing life. And of course, it resonates with me because Karen and I are friends for many, many years. And we've taken this journey as ISTDP therapists at a sort of similar time. And we've shared notes and we've talked about patients and often like we have just these amazing moments with people. You know, they've come about a problem, like sitting in the chair, they've got a problem with their family or whatever. Then the pain goes. And you say, oh, how are you going? And they say, well, you know, I used to have this pain and I just realized I don't have it anymore. Anyway, thank you, Karen, for sharing all of this. Now, what I'd like to do is, before we finish up, to spend a few moments and noticing our bodies. So first of all, could we do a body scan? Just a body scan. Be aware of any tension in your body, especially around your joints, your hips, your shoulders, your jaws. Soften your shoulders down. Breathe in slowly through your nose. Hold the breath. Breathe out slowly, allowing your body to be connected to you. Breathe in again. Purse your lips and blow the air out. Keep your jaw relaxed while you do all this. Be aware of that soft whooshing sound as you exhale. Repeat this on and off during the day to calm your body, to give your body peace and harmony. And as I said in the beginning, you know, be open to allow your body to give you the answers that you need, because your body is there telling you that it's an emotional creature. And thank you all. And next week, we're having someone who will talk to us about exercise.
TMS.
And thank you all.
Thank you. Good night. Good morning.
night. Good morning.
Good morning, good evening, and good night.
That's right.